I guess it was more intimidating to put together this talk than I thought it would be because it's such a broad topic with a broad audience, right? And how do you hone what we do every day, which is a lot of geriatric emergency medicine, into things that actually, microphone's not on? How about that? Is that better? All right, I'll pull it over here and make it right in my face. That's good. So anyway, with the approach to the geriatric emergency department patient, we see a large percentage of patients are geriatric, and I'm sure if you worked in Florida or Arizona, it'd be even a larger proportion of patients that are geriatric. And they come with their own special needs, I guess. That's the bottom line. They don't remember things quite as well. They kind of have a lot of stories to tell a lot of times, and they want to make sure that you understand what it is that's important to them. On the upside of all of that is they're not so worried about every little nitnoid thing, and that sometimes comes back to bite them because they wait way too long to go, and they get really, really, really sick before they show up. And there is a variety of things we're going to talk about along those lines. So we have a few little objectives, and basically we want to look at why they come, what should they bring when they come, what are the most common reasons that they come, and we'll talk a brief bit about hospice, palliative care in the emergency department, and a variety of things that we would love to have them bring, but they seem to never have. So what do we know about the geriatric population? One is it's inevitable to become a geriatric population member unless you die at a young age, right? So we're all going there, some faster than others. And I take care of people that are 100, 102, 103 years old, and they're very vibrant, still driving a car, and I can take care of somebody who's 45 and really can't, so debilitated they can't do anything for themselves. So age really doesn't tell us the whole story. I think the other piece that's changed over my 30 plus years in the emergency department is the engagement of the family in the care of the elder. Partly families are all over everywhere, and they're not necessarily here. It's nice if they call in and can kind of give you the short version of what's going on with their mom or dad, and a lot of them will do that. But a lot of times they're just not available at the right time, or it's the middle of the night and you really don't want to wake somebody up. We do know that the population over the age of 65 is about 15% of the overall population of the United States, and that's predicted to be 20% of the U.S. population will be over the age of 65 in just the short years 2030. 15% of the ER visits across the country are over the age of 65. So I would imagine that's only going to get higher and maybe at a faster rate because they have a higher rate of visiting the emergency department. One thing that I've been kind of tuned into for several years is that a lot of people that are labeled as they have dementia really aren't so much demented as they're just hard of hearing. And so if you talk a little slower, and I'm not the poster child for talking slow, as you will find out, but when I'm taking care of somebody who's geriatric and, you know, kind of gives me a goofy answer to a question, I will repeat it and make sure I get the same goofy answer or say it in a little different way. And a lot of times that takes care of their dementia, just goes away. It's magic, you know? And so that's a learning point that I try to pass on to my residents that, you know, we do have to, sometimes it's just the pitch of your voice that you can or cannot hear with the patient listening. And I try to talk a little slower, directly at them. And the ones that are not hard of hearing, they don't like it when you holler at them. Doctor, I'm not deaf. Okay, got it. So I'll talk normal. And you feel really bad about doing a history at like shouting speed to try and find out what they're there for, because everybody in the emergency department can hear what actually is going on. And so it makes for, I'm not sure what about HIPAA, right? I mean, it's privacy is privacy until you get to the emergency department to a little bit. And we do have to pay attention if our voice is kind of one of those tones that's kind of selected out for patients, that you have to figure out how to get your communication across to them. We're going to go through 4 or 5 slides here that come from the CDC that just kind of frame our problem. The first one is basically the geriatric population and who they are. Let's see if I can show you. So all the graphs are the same. The dark bar is the whole age group over age 65. The light blue is the age group 65 to 74, and then 75 to 84, and then 85 and beyond. So they're all set up the same. So if we look at this overall, there's about 20 million visits a year in the emergency department for people 65 years of age and older. When you look at by age group, there's about 500 per 1,000 patients in this overall group, but by the time you get to age 85, you can pretty much expect that your patients will be in the emergency department at least once a year if they're over the age of 85, and it just ramps up dramatically as we get older. When we look at patients from nursing homes, obviously they have a fair number of visits. 11% of the ER visits are from people from nursing homes, and that gets markedly percent-wise higher as you get older. One of the most important or even troublesome things with the people from the nursing home is the advanced directives piece. So by the time somebody goes to the nursing home, very often they have passed the ability to comprehend what really advanced directives mean. So anybody in primary care would do their patients a huge favor to take the time. And I know you all try to take the time if you're doing primary care, but it's really hard in a 10-minute visit to really explain the difference between do not resuscitate, do not intubate, don't use pressors, don't do anything, just let me go, right? I mean, there's a whole variety of wishes for patients. We end up doing that conversation way more for the first time in a patient's life than probably should be done in the emergency department, in my opinion. I mean, and it's not the right time, right? They are dying typically when we're having that conversation. And do you want to be on a ventilator or not? What's a ventilator, right? So we go through all those conversations. They don't really have time to process, and then they have to make a decision. And when they make their decision, it's final until somebody comes in and changes the decision again. The nursing home, unfortunately, if you look at their advanced directives, are pretty poor. Number one, you can have the choice to make no decision. So I would prefer not to make a decision about advanced directives right now is a checkbox on most nursing home forms. So that is totally unhelpful. Do not resuscitate really comes in once you die, right? Are we going to do CPR? Are we going to do all that stuff to you? And then there's this whole path leading up to the cardiac arrest or the respiratory arrest that's really where the meat of the conversation needs to be. Do you want antibiotics for your pneumonia? Do you want to be put on BiPAP or CPAP? Do you want to have all these invasive things like a central line, an arterial line, Foley catheter, ICU care, all of those things that we can offer? Do you want it? And people that have been in and out of the hospital, universally, the answer is not really. So I think if you look at what people, after they've done it once, generally don't want to go there again if they can avoid it. So having those conversations would be extremely helpful. Another thing is looking at the number of people that come by ambulance. It's no surprise that overall the percent of the elderly visits that come by ambulance go up by age. Another conversation piece to have with your patients is, yeah, the ambulance will take you to the hospital, but they don't take you home. So you have to have some means of getting yourself home. Even if you drive to the hospital, most of the time, if you're going, and especially in the elderly population, they don't come unless they really need to be there. So their chances are that they're going to get a mind-altering drug is pretty high. So they really shouldn't be allowed to drive home. Many of them don't drive at night. And so therefore, if it's after dark, then what are you going to do with them? Put them in the waiting room till tomorrow? You know, that's not really compassionate care either, right? So we have to think about having patients make plans for the inevitable, I'm going to the hospital, how am I going to get home scenario. Maybe it's a network of friends. Maybe we have an ambulance agency in Lansing that will make contracts that's a private agency, not a county or city agency, that will make contracts with patients, like an insurance plan that will do ambu care for you any time of the day or night for a fixed fee per year. So exploring what's available for your patients in the community that you live in may help them dramatically be able to navigate that without having to call somebody at 2 a.m. to come and pick them up. Looking at what brings the patients into the emergency department, overall, the number one thing is injury. And that's 30% of the ER visits are for injuries in the elderly. And of those, about 50% are related to falls. So one of the handouts you got today, we're going to go over in a little detail. And I'm going to pass these around if you guys, if you didn't get one, take one of each.
And those are also available on the
Yeah, those are on the MOA website too, domoa.org/geriatrics. And so feel free to print them out and use them. One of them's a CDC website thing, so that should be free to distribute to anybody because we all paid for it. And the other one is something I created myself, so I'm telling you, you're free to use it for your patients. And basically, that's a basic simple card that you could fold into your wallet. It's got a front and a back. This wasn't quite printed right, it looks like, so it doesn't cut evenly at the halfway point, but really you could get 2 per page if you put it on the printer just exactly equally. So the big issues are falls and some of the other things we'll talk about here. And when we look at people that are elderly coming to the emergency department, what percent get admitted? Overall, it's about 36%. Right here for everybody age 65 and older if you put them all in a bucket. But if you take the 85 and older, it's about almost 45% of people will, if they come to the emergency department, are going to need a hospital admission. So that's something to keep in mind. When we talk about what they should bring, mostly what do they bring, it depends. Memorial Day is coming up, right? So families that want to take the Memorial Day weekend off often have a suitcase packed for grandma. And they bring grandma to the emergency department and tell you she's been goofy for the last 3 days. And then they are nowhere to be found for the rest of the weekend. That, unfortunately, is more common than you would like to know. And we do have to kind of work with that. But oftentimes they don't bring the stuff we need, and they bring a lot of stuff they don't need that then gets lost. And then we have to worry about where did security put it. And how could you help do all of that? If you look at what pieces of information that we would like to have, if they have a primary care doctor, which is a big if in this day and age, because a lot of them, their doctors have retired. They've outlived their doctor. They've changed insurances, which is one of the bigger reasons to change doctors. So their primary care situation is in a state of turmoil for many of the geriatric patients, right at the wrong time in their life, right, where they need to have somebody that knows them, understands them, is kind of see them to the end of the road. That doesn't happen for very many of our geriatric patients anymore. The healthcare system is also structured so that it's very much more disjointed than it was, as we know. So they come in, they get admitted to a hospitalist service. They go home and they have a primary care doctor. Hopefully you get the records, but maybe you do, maybe you don't. They certainly try to send paperwork back and forth, but you may not get it before the patient gets to the office, so you really don't know what they went to the hospital for. But if they came with a packet of information themselves and we trained our geriatric patient population to know what's important for their benefit, this has really very little to do with our benefit and very much to do with their benefit when they come to the emergency department, a list of their current diagnoses that's accurate. You know, it doesn't help if they had, an ingrown toenail 3 years ago. That doesn't have to be on the list, but the fact that they had C. diff last month, that's pretty important, right? Especially if they're having diarrhea. Current medications and kind of what times of day they take them so we can keep them on the same schedules. Allergies with what kind of reactions so we can get that accurately entered into our electronic record. What's their past surgical history, their advanced directives. You know, that should all be in one big packet, just in a folder. If you can get them trained to have a patient folder that's basically goes with them, we're happy to add the most current EKG, the most current chest x-ray or CAT scan report to their folder, whatever needs to be added that's really of importance to their medical record. Having patients have that, I think, helps keep them safe. power of attorney form. A lot of patients have a family member that's a power of attorney, but many of them in nursing homes are assigned by the state to Mid-Michigan Guardianship or some other guardianship service that really has no idea who they are. And so they really have to have some form of paperwork with them. And then who are their doctors? I mean, quite frankly, you could have taken out their gallbladder yesterday and they will not know your name. And that's always been astounding to me, but that is, who's your cardiologist? Who takes care of your lungs? Who's your GI doctor? I don't know. It's the one up on that road, that one up by Myers, okay, yeah, I got it. And, once you know the town, you're pretty well covered, but otherwise, if you don't know where their offices are. We can give them the gown, we can give them the toothbrush, we can give them a warm blanket, but all this other information, if they came with it, really would make their care safer. It would decrease their adverse events. It would decrease them getting care that they don't want. It would decrease the risk of getting a medication that they're deathly allergic to, all of that stuff. They come in with the impression that it's all in the computer, doctor. I can't tell you how many times a day I hear, well, doctor, you should have all that information in the computer. Why do I have to tell you this? Your doctor's computer and our computer don't talk. We have 6 EMRs in the city of Lansing that are just institutional EMRs that don't talk to each other. So there's 2 different hospital systems, a university system, the VA, the health department, all of those don't talk. So if they go to care in any of those places, we won't get that information. And then many of the doctor's offices are on something completely different altogether, and they don't care for their patients in the hospital a lot of times anymore. So therefore, it's very disjointed. So getting the patient to understand that it isn't all in the computer, where it's readily accessible any time of the day, is a big coup for your patient. Giving them the after-visit summary is helpful. And a lot of them don't have anybody that's medically savvy. My dad always says to me, Mary, I don't really know how anybody does it that doesn't have a doctor in the family, right? And my dad's got pretty uncomplicated health problems. But still, it's one of those things that if you don't have somebody that really knows what it is and who you are and what's going on with you, it just makes it that much more complicated, especially if you're hard of hearing and things like that. So where should they stick all this important information? EMS is taught, since a lot of them are going to come in by ambulance, kind of look on the refrigerator door. They're also going to look on the bedside stand. They're also going to look on the kitchen table. They're going to go to the medicine cabinet. Those are kind of the big places where the ambulance crew is going to go looking for stuff. If it's all in one spot and you have them get a big sign, either they can put one sheet on the refrigerator door that says, this is James Jones's medical history, and it's got one sheet, everything, all we need to know right there. The paramedics will grab that and bring it to the hospital. We don't need their pill bottles and all that stuff. But if they don't have that kind of thing, or they could put a sign up that says it's on the kitchen table in a green folder, and that paramedics will pick up the kitchen table green folder and bring it in. That is extremely helpful, especially to somebody who's got acutely altered mental status, right? We can't figure out what's going on. Somebody called for a wellness check and they found the patient on the floor. They've been there for who knows how long. Maybe they're in rhabdo, whole variety of things go on with these people, and we don't have any history. And we don't really have an accurate name, because everybody becomes a Doe, like a John Doe or a Jane Doe, until we can have somebody actually identify them. So that can take days. And so your patient has a Doe record with a whole bunch of data that's being gathered under a Doe name that somewhere in the future, weeks down the road, will get merged to their real medical record. And so in the meantime, there's 2 sets of data out there on this patient, and the real set of data when they were normal is not available to anybody because we don't necessarily have their name. And EMS also grabs all the patient's medications, not necessarily all theirs either, everybody that lives in the house. They go clean out the medicine cabinet, put it in a paper bag, and bring it to the emergency department. So we spend a lot of time looking at pill bottles that don't even have a female name on them, and we got a female patient, okay? So that's takes away time from their care. So I think if they understand those are the distractions that are going to make it likely that they're going to have an error happen to them, people don't want to have mistakes happen to them. So if they know that it's important to them, they probably will do this. They just don't even know. Recycling their old meds is extremely important. and I can't remember, I just saw an ad, I don't know if it's Walgreens or Rite Aid or one of those. They have a drop box right in their front lobby of every one of their stores that people can put their meds that they're no longer using in. Many communities have medication recycling days where you can bring any old meds that you don't want to, they don't want them flushed down the toilet. They definitely want them in a recycle thing. And then they should carry a brief health history card, which is what I gave you a sample of, in their wallet. That will fold up nicely into your wallet. It's got the most important stuff on it, because a lot of the stuff doesn't happen at their home, right? They have a car crash, they fall at the mall, they slip on the ice at the restaurant, and they have no information with them. If they have that in their car, we do go through people's wallets looking for health information, so it is helpful if we find something. Anybody who has a chronic medical condition should actually have one of these cards in their wallet, even if it's just hypertension. You know, that's if they take no meds, no allergies, no medical history, that's great. But that's not the norm. Medic alert tags for your patients with very complicated histories or diseases that are likely to cause altered mental status are very helpful to the emergency department. Yes.
Some of my patients' kids, my geriatric patients' kids are putting their histories on thumb drives and those little CDs for their wallet. Did you guys use those?
You probably could use a thumb drive, a little CD, probably not, because a lot of our computers don't have CD readers, but we do have USB because we use the mouse plugs into USB port, so we could do that. And if they put on when the last update of their whole history thing was, they'll put a date at the bottom. At least we know when it was current to. That's helpful. In the medic alert tag, we do look for those. Do you have a seizure disorder? Are you diabetic? Have you had a stroke and you got right hemiplegia? All that stuff helps us know that, oh, this is not probably a new stroke. They already have right hemiplegia. We know where we're starting baseline. That's very helpful again. Mostly, this is all for your patient, right? We can eventually figure it out. It slows it down. It makes it more likely that they're going to have a problem, more likely they're going to have a complication because we don't know the correct information. I mean, we are kind of the masters of working with our eyes blindfolded and our hands tied behind our back, right? But that costs on the patient side, right? The more information we have that's accurate, the better your patient's care will be. So why don't your patients go to the emergency department when they should? Every one of you that has an office has a answering thing that says, if you think this is an emergency, please hang up and dial 911, right? And go to your nearest emergency department. That's fairly standard. Why don't your patients come? The bottom reason is actually the most common. I thought it would go away, and so I waited, and then it didn't, and so now I'm here. Some people wait 3 days with their acute stroke. Some people wait 3 days with their diverticulitis that's perfed, a whole variety of things. Some of them are very worried about the cost, and that's very real. I mean, ER care is very expensive. And they've kind of wised up about observation things. And they also aren't very educated. They watch TV a lot, but they don't really translate that it's them that's being talked about. If you have facial asymmetry, if you can't talk, if you are weak on one side, you need to call 911. Well, that must be for some old person that's having a stroke, right? I'm not the old person having the stroke, right? So I think there's a lot of that, that's for somebody else kind of information. Heart attacks? I mean, how many doctors do we see that have heart attacks that have been drinking Maalox for 2 days? I've got a couple partners that have done that. So, we're well educated on that, but it's not me. It must be my patients, right? So it's not going to be me. The observation admission, which is the big push from the Medicare system, I guess is the best way to put it. If you don't meet all the different criteria for a full admission and you aren't admitted for 2 midnights, your hospital stay is not covered by Medicare. So that is a mammoth noose around somebody's neck. When the bill is $10,000, $15,000, $20,000, $30,000 for an observation admission, depending on what you're doing. If you're going to get a TIA admission and they can get you through the workup in a short order and get you home, you might get the bill for the MRI, the MRA, the carotid Dopplers, all that stuff. And that's all fairly expensive. But we also know that if they don't get that workup, their risk of stroke in the next 7 days is quite high, and those deficits will be permanent. So we have to kind of balance what we do. Many of our patients will sign out against medical advice if we say that it's an observation admission. So that really puts them at the crossroads of, should I take care of myself? Or should I worry about not being able to feed my family, right? I won't be able to afford my meds, all the other things. And those are very real concerns. There's a new law kind of winding its way through, a recommendation. I think it's actually trying to become law, that the emergency department is going to be mandated to tell everybody that's being admitted observation that they're going to be admitted at observation and that their health care will not cover their costs. So you talk about we're going to have trouble, right? So somebody will figure it out. One of the end arounds on this is hospice palliative care, right? And that is the latest big focus for hospitals that are losing their shirts on these 30-day readmissions, because that also is not covered. If you get readmitted within 30 days for the same chief complaint, which of your patients with COPD that's end stage aren't in the ER at least twice a month getting admitted because they can't breathe. CHF is another one. Diabetes that's poorly controlled is another one. So if they're covered by Medicare, those readmissions, nobody gets paid for those. The hospital doesn't get paid. The docs don't get paid. The lab doesn't get paid. Nobody gets paid. So when these patients show up, we want to make sure that and there's no onus if the patient's non-compliant. We own that too. So just so you know, that's a huge thing. So there's a big push on hospital parts to get these patients into hospice and palliative care, because hospice and palliative care must be a different budget line in the Medicare budget, because they do pay for hospice palliative care, whereas they won't pay for a readmission for COPD, CHF. They will if you're under hospice palliative care and it's just a temporary thing to kind of get things better at home. So when we looked at, I did some looking at what's the average length of stay in hospice care. And actually the average length of stay is just over 2 months, 71 days. This is 2010 to 12 data. And then when you look at the median length of stay on the right, it's actually less than 20 days and going down. So it's not very long that people are in hospice palliative care, but there are some that are there for more than 180 days. And those big spender people are the ones that are costing the government a fair amount of money and that they're quite worried about. And that's what they think all of hospice palliative care is going to go to. So I think they're nervous about that. But when you actually look at hospice care, almost 2/3 of people spend less than 30 days in hospice before they die. So that's a very short period of time. And then when you look up here on the purple thing, it's 11.5% are there over 180 days. And those are a little more expensive patients to take care of, right? If everybody's going to go in and be dead, okay, we'll do it, right? But they're not all going to do that. So a lot of patients are resistant, at least when we approach the topic in the emergency department to hospice palliative care, because that means they're going to die. And somehow that hasn't circled their brain when they've got end-stage CHF, end-stage COPD, whatever else they've got, right? They're going to live forever. They're trying to get to 100. Number of people that tell me that, and I'm thinking, really, you've got all these comorbid diseases and you think you're going to get to 100. And some people have the fixed notion that it's only for cancer patients. And I don't have cancer, so therefore I'm not going into hospice, because everybody goes into hospice is dying. And so we try to do some work with that as far as that, no, it's not just for cancer. And as you can see, when you look at the hospice admissions, there's a whole variety, including stroke, lung disease, heart disease, dementia, liver disease, kidney disease. Those people all can benefit from hospice care, especially towards the end of their life. Well, they do. She said they think that you've given up on them. And I think to some extent that's true. That's what their thought is, but that's not actually what happens. And we all know that, but they don't know that. So somehow there's got to be a lot more education When you just look at the aspirin ad for MI, right? Take a baby aspirin if you're having chest pain on TV. How effective with that? Amazingly effective. It's almost no patient that comes in with any form of thought that they could be having a heart attack that hasn't already taken a full dose aspirin. So that's been a very effective means of getting the word out. This is probably one of those things that the Geriatric Society should start broaching in primetime television, right? That we think about that. There was an interesting article that was published in the JAOA, and this was a group, I think, a family practice at Wilton Hall or Wilford Hall down in San Antonio that took 1,000 people or 100 people and just asked them what they thought their chance of survival was from CPR after an in-hospital cardiac arrest. So 50%, 81% thought that it was going to be over 50%. And 23% actually felt that it would be over 90% likely that they would survive and go back to normal. And then only 10% felt that it would be less than 10% that likely that they would survive an in-hospital cardiac arrest. And they also asked them, where do they get their healthcare information? Television is number 1, doctor is number 2, and a combination is number 3. Interestingly, 44% of these people had signed do not resuscitate orders. So there is a distinct disconnect between the paperwork that they sign and what they really understand. And that plays out very vividly in the emergency department, that they really don't get it. You know, they sign these papers. No, I don't want all that stuff done. We did a survey on end-of-life wishes, a study, and 75% of the people wanted to die at home in their own bed. I mean, that was their end-of-life wish. 50% of them wanted CPR done and would want to be intubated. You can't have both, right? And so it's amazing. There's just a lot of education that still needs to go on about that, and everybody can help with that. Interestingly, JAMA did published an article that was from the 1990s that looked at TV drama series and what was the rate of survival. If you were in primetime TV, 67% or 75% of their people survived a cardiac arrest. If it was just TV over the 24-hour period, 67% of their people. So if you're getting your information from TV and everybody lives that dies on TV to come back for next week's show, it makes it pretty believable that that's what they would think, right? Well, yeah, it's just a passing problem. Everybody can fix it, right? It doesn't work that way. Interestingly, a Dutch study did a meta-analysis of all patients over the age of 70, and they looked at survival at out-of-hospital cardiac arrest. And your rate, if you're over 70, is 4.1%, that you're actually going to survive it. That doesn't mean you're going to go home neuronormal. Go home neuronormal 0.6% for out-of-hospital cardiac arrest. I think armed with those numbers, it helps you explain to your patients that, yeah, they might get you back, but where you're going is a nursing home. Is that what you want? And that, you know, when you put it like that, I think it does make a difference for your patients, right? So just education, I think, will help. The other thing I think we need to educate is this: game over, right? Fall and break a hip, 30% are going to be dead within a year. Have bad COPD, 7 to 43% are going to be dead within a year. 2-year mortality, 50%. Okay, those are grim numbers for people that really think they're going to live. I didn't look up chronic renal failure, but I'm sure it's just as grim. CHF, 1-year mortality, 17 to 34%. If you have a flare of acute pulmonary edema, the initial mortality is 27%. 4-year mortality, 67%. Have an ischemic stroke, 7% are dead in a week. 30-day mortality is 12%. 1-year mortality, 25%. So those are numbers that, you know, we can look at statistically and provide families with that kind of information. When we look at major reasons to visit the emergency department, trauma leads the pack, like we talked about, falls, but medical visits are right in there, kind of commingled for a large percentage of those. It's often a medical reason that leads to the trauma, especially the falls. I've got a urinary tract infection, I got frequency and urgency, and I'm getting up to go to the bathroom every 15 minutes, and I trip in the middle of the night, fall and break my hip. well, you're a trauma admission because you fell and broke your hip, but the real reason you fell was because you had a urinary tract infection and you don't have good balance, right? So those two things kind of mix together quite regularly. Of the medical conditions, the most common visiting patient is the altered mental status. They're actually fairly easy to sort out, but the residents, when you pick up the 85-year-old lady with altered mental status, it's like, okay, what am I going to do with this? Number one, you're not going to get a good history. Number two, the physical exam is going to be suspect because they can't cooperate very much with your neuro exam, right? And so we have to look at what we can do for these patients. Many of the visits are due to polypharmacy, though. I mean, many of these patients have their altered mental status because they're just on so many meds. And they're on meds for the side effects of the meds that they were on. It just is a vicious cycle. And sometimes if you spend the time to look at their med list and see if there's something, even one thing you can get rid of on their visit list, that would be helpful for them. The three drugs that account for 50% of the adverse drug events are any of the anticoagulants, any of the antidiabetics, and then any agent with a narrow therapeutic window, like digoxin, phenytoin. Those are two fairly common narrow therapeutic window adverse drug event. And the risk for adverse drug event is directly proportional to the number of drugs that you're on. So if you're on one or two drugs, your likelihood that you're going to have some sort of a adverse event is 13%. If you're on more than 7 drugs, then it's 87% likely that you're going to have at least one adverse drug event from just taking the pills. This is another statement that I think if we put up in our offices, if we take care of geriatric patients, we should put it up in the ER too. Every second of every day in the United States, an older adult falls. So that's the number one cause of injuries and death from injuries. 2014, it was 29 million falls, 7 million injuries, $31 billion spent. Okay, so there's a lot of cash going out. The other thing that's not so obvious to a lot of people is the amount of alcohol that's consumed by some of the senior citizens in our crowds, right? A lot of them substitute it. They're lonely. They don't really have anything else to do. I mean, I just had an old woman that came in that had just been through alcohol detox, for God's sakes. And she went home and found her bottle of alcohol and actually passed out in front of her sister. Well, she blacked out from being just wasted drunk. I mean, her alcohol level is 374. And she was walkie-talkie at 374. So she's not a novice drinker. And right? I mean, she was competitive with most of our regulars. So I got to tell you that it's not uncommon that we see senior citizens. I check a fair number of alcohol levels on our senior citizens that fall, have altered mental status, any of that kind of stuff, because you never know. A lot of them are just closet drinkers, right? Nobody really even knows. And a lot of the really senior citizens are still well-dressed, well-kept. They started drinking way later in life. Their spouse died, something else happened. There was an emotional cut point in their life, and they really don't have anything else to do. Highest rate of traumatic brain injuries in the ED, hospitalizations and deaths are due to people that are over the age of 75. So really, fall prevention is our number one thing, and it really increases your risk of mortality. An interesting study in Brazil, they looked at people over the age of 60 who had a fall with an orthopedic serious fracture, and then they compared it with age-matched and comorbid disease-matched patients that didn't have a fall with a fracture, and the people that had the fall with a fracture, 25% mortality in a year, otherwise 4%. So the fall itself is responsible for a large amount, and a large percentage of them don't go home normal or go home at all. So one of the things I handed out is that nice color page, and that's from the STEADY algorithm. And the STEADY algorithm it came from the CDC. When I was putting this together, it is, stopping elderly accidents, deaths, and injuries. That's what it stands for. And if you just Google STEADY, STADI, there's a whole series of patient education materials that are wonderful, that could be used in any office for these patients. And basically, they recommend for every visit that you screen with these 3 questions. Have they fallen in the last year? Do they feel unsteady while standing or walking? And do they worry about falling? If they answer yes to any of those questions, then you need to do some further evaluation. And this is the whole thing. When we look at it, if they answer no to all the questions, they're really low risk. And really, you just say, well, because you're 70, we need to be thinking about this kind of thing. I want you to do some stuff in your home. These are things that are important to you to keep you independent. And look at their vitamin D levels, their calcium, make sure that that's osteoporosis is being managed, and make sure they're doing some sort of physical activity. And they're on their way, good to go, reevaluate them the next time. If they answer yes to any of those questions, then they do recommend you do the timed up and go test, which I had to look up because we don't do the timed up and go test in the ER, but basically it's have them sit in a chair, stand up, walk 10 feet, turn around, walk back, and sit down. And if it takes more than 12 seconds, they are likely to have a fall. They're a fall risk patient. So that and then the other one was a 30-second chair stand. How often can they get up and get down from a chair in 30 seconds with their arms crossed in front of them so that they're not pushing off on the arms? So if they push off on the arms, they failed the test, they're a fall risk. And then the balance test is a little more complicated, probably not a screening test. And when you screen for falls, if they fell but they didn't have any injuries, or they've had no falls but they have some trouble, they're a little more moderate risk, and you need to do a little more intervention with them as per the algorithm. And if they've had any injuries or more than 2 or more falls, then they're definitely high risk fall patient and really need to get them into physical therapy and things that will help with their balance and strength training, if at all possible, depending on what they have. We look at traumatic brain injuries in people on anticoagulants, which is 90% of the adult population because they all have AFib, right? And the recommendations now are everybody needs to be on anticoagulation if you have AFib and kind of any one of the other diseases. And so overall, the rate of intracranial hemorrhage for somebody on an anticoagulant with a fall is 7 to 8%. Typically, it's about 5% if you fall. And you don't have to hit your head. Remember, our bridging veins are stretched as we get older because our brain atrophies. And so all you got to do is rotate your head around a little bit too fast, and you can stretch one of those bridging veins and tear them and have a subdural. We see a lot of people with subdurals that have had them for weeks, and they're really not there for the subdural. The big thing with the literature is, what do you do with these people? We scan them all. That's our current recommendation. Everybody gets a head CT for a fall, especially if they're elderly, especially if they're on anticoagulation, because of those reasons. If they have a bleed, that's great. Now we're going to neurosurgery, and now we got a disposition and we're good, right? What do we do with the patient that doesn't have a bleed but is still on anticoagulation? If they're on warfarin, we've got to worry about checking their INR. Everything else we can't monitor, right? I mean, we're just stuck with, we don't know where you're at, but we know you're anticoagulated. And the mortality goes up significantly for those who have an intracranial hemorrhage compared to those that do not with the fall. And we can basically, if they're neural normal, they've got a reliable family person that can monitor them, could send them home with a negative CT, provided there's no other injuries. If the only thing we're worried about is a delayed bleed. A small percentage of these people, maybe 5-10%, will go on to have a delayed bleed within 24 to 48 hours. And so if that happens, then they're going to need to be readmitted. The Canadians do a lot more of these decision rules than we do, because they've got a healthcare system that doesn't want to pay for anything. And so, and they've got a captive audience, right? Everybody's doing the same thing. So they do these huge studies on people, and then they make recommendations, and then they prospectively validate them kind of around the world. But their data suggests that people that have reliable caregivers and somebody that can watch them will be willing to stay with them for a day or two, because it can be 2 to 3 days out that you'll get the delayed bleed, that it's safe to send them home if their initial CAT scan's negative. Now, if their INR is like 10, that's probably not a wise idea. But for any of the other ones, it's probably safe to do that. The other big thing we see is this altered mental status, and the big decision is this dementia? Is it delirium, or is it a combination of the two? Many times it's both. So there's this very cool scale. Delirium versus dementia briefly is dementia, been there a while, nobody can really tell you when it started, and it doesn't really wax and wane. It kind of progressively just goes downhill. Delirium, on the other hand, generally they can tell you, you know, grandma was normal until 2 o'clock yesterday afternoon, and now she's like seeing green men in the living room and, you know, all that kind of stuff. It's generally fairly short onset before somebody seeks intervention, and it will fluctuate throughout the day. It will fluctuate within the hour. That's much more likely to be delirium. Delirium in the emergency department is underdiagnosed. I mean, we're always told, and really if we make the proper diagnosis, the patients get care for delirium that actually gets them back to their baseline. For my experience, the quinolones are probably the biggest drug to cause acute delirium in the elderly population that were otherwise normal. They come in 3 days after being started on Levaquin, especially Levaquin for their COPD or whatever. And they're like, there's children playing in the front yard. My husband came to visit me, who's been dead for 10 years, in the living room. And you can just, what meds were you started on, right? Well, Levaquin. Okay. So if we stop the Levaquin and everything else is okay when we check them out, it's probably the Levaquin, and you take them off of it. And 3 days later, they're back to normal. And so if I put somebody on a quinolone, I actually tell them, grandma may get crazy. And if grandma gets crazy, you need to stop this medicine and go back to the doctor. Either come back here or whatever, because it's most likely from the medicine. If she's not crazy with the urinary tract infection to begin with, then probably it's the medicine that's changed that's making her not right. So there's a very quick, brief delirium dementia assessment tool called the confusion assessment method. You have to have features 1 and 2, and then either 3 and 4. So they have to have evidence of an acute change in mental status from their baseline. They have to have difficulty focusing attention, like they're easily distractible. Anything, you start asking them questions and they're off wandering someplace else. And then during your interview, it fluctuated from one to the other. All of those need to be yes for it to be delirium. If you get through the yeses on that, then you need one of these 2 things: disordered thought or altered level of consciousness. If they're awake and alert and normal, that's probably fine for them, but it doesn't get you into the delirium class. But if they're stuporous, comatose, any of those, then any one of these things other than alert will get you into the delirium if 1 and 2 were met. And that's a better thing to be. If you want to be one or the other, you want to be delirious, not demented. So we work on that. There are several other things that can cause traumatic injuries that we're really not going to spend any time on other than to think about them. Syncope, patients that pass out, patients that have a seizure, patients that have medication changes often can have complaints that lead them to the emergency department with altered mental status. And we talked about not all trauma that comes to the ER has actually got a traumatic etiology. It wasn't I tripped and fell over the rug. It's I passed out from my heart stopping for 10 seconds, and then I woke up on the floor and my hip was broken and I couldn't get up. So paying attention to the events leading up to the accident is part of what we do regularly. The other thing is to think about is you don't want to ever end up in the ICU for more than 3 days. So the studies on that are, this is again the Dutch. They must have another very well organized system that looks at data, because a lot of this stuff comes out of the Dutch. People that are in the ICU for more than 72 hours, 26% of them will die in the ICU. For the 1 year mortality, if you didn't die in the ICU, 28% are going to be dead of the ones that lived. And half of those are going to die while they're in that intercurrent hospital stay. And most of them don't return to normal function. And so that's really not what people want to do. So we want to try and intervene before they get so sick that they end up in the ICU. And that's the downside of not paying for observation care, is a lot of these patients then wait until they know that they're sick enough to be admitted for 2 midnights, which is generally when they're going to end up in the ICU with an ART line, intubated, central line on 3 pressors for their septic shock, right? And that's a tough drag back from the dead. And it doesn't bode well for the patient. Belly pain is an interesting thing for the elderly. 60% of patients that are over age 60 are going to actually be admitted because of abdominal pain. 20% are going to go to the OR in the next 2 weeks, and 5% of them are going to die. Those are astounding numbers when you look at just all the belly pain patients that we see. And there's a variety of reasons for this. The elderly don't have the ability to mount an inflammatory response like younger people do. And so they don't get as big a white count. They don't get a big CRP. They don't get a big SED rate if you're checking those numbers. They don't get massive peritonitis, so they don't get the rebound and guarding on physical exam. Therefore, a lot of these patients are missed in the emergency department, go home, they're diagnosed with something that's not as serious, and then they come back deathly ill. And that's, something we're educated about on a regular basis. Oh, they're 75 and they've got abdominal pain. Chances are you're going to find something that's going to either admit them or send them to the OR. It's something we've got to really be vigilant for. But same for the office. I mean, a lot of your patients come to the office with abdominal pain that they've had for 2 or 3 days. And you're like, well, they don't really have any rebound or guarding, or they aren't going to get that until it's like way, way, way too late. So again, something to think about. The other I have this little personal thing about fevers. So I still touch all my patients. I'm sure all of you do too, because you're good osteopathic physicians, but a lot of our physicians don't touch their patients. And you walk in and the nurse has got a temperature that says their temp is 97.8 or 98.3 or whatever. You touch them, they're like burning up. It's like, okay, well, there's no way their temperature is normal. Okay, so do a core temp on those people. My experience has been, and actually we're studying it right now, is that if you have dry mucous membranes, which kind of goes with everybody on diuretics, everybody who's sick, everybody that's dehydrated from vomiting and diarrhea, they all have dry mucous membranes. Their oral temperatures with those digital thermometers are grossly inaccurate. And so we get a lot of rectal temperatures in the emergency department. And my biggest delta gap is an oral of 97.5 and a rectal of 106.5. But usually it's at least 2 to 3 degrees different. And the rectal probes change the scale so that they're equivalent. So it's not like it's because rectal temperatures are a degree higher to begin with that it's off. It's because it's off. How about what? We don't have any of that in the emergency department. There's one that they, when they do pre-op that they run across your forehead. I think that's for well patients. You probably could. I have no idea, but we don't use those in the emergency department. We use temperature Foleys and rectal thermometers. Pardon? You'll meet somebody else because I'll be gone. So just something to think about. Yeah, I mean, we do it on kids all the time. And a lot of them, they'll roll their eyes at me when I tell them we're going to do a rectal temp. And they go, I haven't had that done since I was a baby. And I said, and you don't remember it. But it's okay. It's the only accurate temperature that we have that will help us make the decision at this point in time. I mean, even bioxes. I mean, people that are in septic shock and they have cold digits, I mean, they're vasoconstricted. I can't imagine that a finger temperature in our population would be good. I mean, I wouldn't even use the temperature probe that they use pre-op because I don't think that, given the circumstances that are people that are septic, they become vasoconstricted and very clamped down. And I don't think you'd get an accurate cutaneous temperature. Yeah, I mean, it does. Yeah, it just doesn't work. So what can you do to keep your patients safe, and what can you recommend to them? They should get a senior evaluation for driving. This is a big deal, okay? A big deal to recommend this, and the older I get, the more likely I'm probably going to be in that class. Have them put grab bars and get grab bars installed, and it's not a towel bar, Okay, so a towel bar is not anchored to hold their weight. Okay, you got to put a grab bar in. They need to be in the shower. They need to be on both sides of the stairways. They need to be at the side of the toilet. You need to have them along a hallway if they've got a long hall that doesn't have like wainscoting or something that's got a lip on it that they can grab on to steady themselves. I send a lot of patients home with urinals and prescriptions for bedside commodes when they got to get up in the middle of the night. A lot of falls happen in the middle of the night. Certainly night lights help, so because they don't put their glasses on and they don't turn the lights on because they don't want to wake up the other person that they're sleeping with. And so we run into those kinds of problems. But if they had a urinal or a bedside commode, they could just get up, go to the bathroom, and go back to bed. And less walking is better in the middle of the night. Get rid of the rugs. Rugs got to go. Even if they've got the grippers on the bottom, it's probably a good idea if they have any kind of balance problems or proprioception problems, they should have no rugs in their house whatsoever. And they need to be encouraged to use their walker. I know a lot of patients are very resistant to that because it makes them look old. And I then promptly say to them, well, let me tell you something. When you fall and you break your hip, you have a 30% likelihood you won't be here next year. So you get to pick. It's your decision. And that's just kind of how I say it. It's your decision. And then the daughter will be sitting in the corner saying, well, they've got a walker and a cane and we got a wheelchair and we got all this stuff, but they won't use any of it. So one of those things. And the other thing is a medic alert for your people that are alone. I think that is, and I don't know what it costs, but if they can afford it at all, I think and it would work in their environment. It definitely is a benefit. I had a patient in last week that actually had one that was sensed whether she fell or not for change of position. So for your fall risk patients, that I think is, people that lay on the floor for 4 or 5 hours get CPKs of 4,000 or 5,000. They go into rhabdo, and then we got to treat them to try and keep them from going into worse kidney disease or frank renal failure and going on dialysis. So it's not a minor thing to lay on the floor all night. Yes.
A case manager to come in, if you see an elderly person who's fallen, maybe without a fracture, come and talk to them about the DMED?
No, not really. That's really up to the doctor in the emergency department. We sometimes can get case management to help with some of that, but they're so busy with the psych patients and we've got a lot of other needs in the emergency department that aren't being met by society as well. So we have to use our case managers for, psych placement that takes sometimes a week to get somebody out of the emergency department. I mean, we're holding people for a week. Geropsych patients can stay there for 3 or 4 days because we don't admit on the weekends. Really? That's nice. I wish I had that job, right? I mean, so in summary, what can we do? We can talk so they can hear it. Tone down your voice so that it's in their range, if at all possible. Speak louder, speak slower, look directly at them. Kind of educate them on falls have a mortality. Have a conversation when you diagnose them with COPD, CHF, diabetes, chronic kidney disease, stage whatever, that this means your life is going to be a little bit shorter than if you didn't have this. It doesn't mean you're going to die tomorrow, but good idea to get your advance directives in order, get your power of attorney while you still got your wits about you and you can communicate what it is you want, because somebody will make that decision for you, and a lot of times it won't be what you want. You can use the confusion assessment method for trying to figure out delirium versus dementia. Make sure they got a complete up-to-date med list, allergy list, surgery history, past medical history, just typed up somewhere that can be readily available, and get them to recycle their old meds. We get bags of stuff, and like I said, they're not often on the meds anymore, and that's a problem. And if you encourage them to avoid the see if it gets better mentality for many of their symptoms, that they'll do better. I mean, when they get old, if they've got symptoms, probably getting, especially stroke symptoms or heart attack symptoms, they probably should just go to the emergency department. And again, we would like them to kind of get in the habit of bringing their healthcare folder. So if you encourage them to bring the healthcare folder to their visits to you, and then they just get in the habit of taking it wherever they go, I think that that would be helpful. They all want to walk like this, right? They don't want to walk like this, but if they don't use this walker, they're going to end up dead in 30% of them. And take a look at what kind of shoes they wear, okay? Because a lot of the elderly patients with edema can't fit into real shoes, and so they wear flip-flops. Or bedroom slippers, or worse yet, flip-flops that, number one, have no support, but also come right off their feet, and those make them an increased fall risk. This is kind of the reason a lot of people want to stay alive, is they got grandkids, they want to see them grow up, they want to travel, they've got all these things they've put off in their lives while they were working, but they need to understand that there are things they got to do to continue to be there. It's not a passive experience to get to age 90. There's a lot of work that has to go in with that. Any questions? We do use home health care, but that generally, again, doesn't get referred out of the emergency department. So that becomes... Oh, absolutely they will. I think they need in-home assessments. I would totally support that.
The primary is to cite those orders.
Right, that's exactly it. I mean, the ER can't do that. I mean, there's some things we can't do on a we can't be responsible for their whole care from beginning to end. Having a primary care that's needs to do the referrals, but I think if we bring it up to the patient, you need to talk to your primary care doctor about maybe getting an in-home assessment done to make sure that your home is safe as it can be for to stay independent.
Post-hospital stay, you're supposed to come in within 2 weeks and probably within a couple of days. If they don't look good, you still have a home assessment. They're to look at them, do you need any help with their activities of daily living? Are you able to take the bathroom? Ask them all those questions.
Right. Yeah, I think this is a team sport, right? I mean, this is not just the ER. We have to rely on the family doctor doing their piece, the geriatrician doing their piece, hospice palliative care doing their piece. Everybody's part of this, but if our goal is the patients at the center, we can make them healthier longer, I think, by being verbal just about where their risks are and kind of pointing it out, because I think we all live with blinders on.
Would you say that all patients who fall and have head trauma and are on anticoagulants should be seen within 72 hours by their primary?
Absolutely. Actually, we try to get them rechecked within 24 hours. We recommend that they call the next day and get in to be seen, because it's, it's one thing if, I've got somebody that will watch me, but we don't really have the ability to assess the wife to see if she's really got dementia. I mean, she may think Jimmy's fine, because Jimmy looks no different than before, but she can't remember really. So part of it is we don't have the ability to spend all the time to try and figure out who's going to do all of that. We need to make sure that we think that they're capable and we can ask them some questions and things like that. But early dementia is a tough diagnosis to make in 5 minutes, I think.
Do you do any testing on your 10A inhibitors?
Yeah, we TEG testing, which is kind of a fancy way to figure out what kind of bleeding problems they actually have and where the issues are. We do that more on the trauma patients, but these fall patients are...
We're doing it more now because the trauma service doesn't want to observe them overnight or anything.
We still got a trauma service that will take every fall because they need their numbers. God forbid if they ever get to their numbers.